role is supporting folks who are interested in education scholarship, and the other part of my role is conducting research and education scholarships of my own program of research. So what I hope we can cover today and that you'll take from this session is just the general role and importance of quality assurance in geriatric psychiatry. And then some of the key terms and methods associated with quality assurance. And I'm hoping that because it's kind of interactive, we'll have a chance to chat, and you can consider quality assurance in the context of some of the cases that I've brought in, as well as how it might apply to your own specific contexts. It'd be great to actually know, so maybe we can all just kind of introduce ourselves, just so I know kind of who's in the room. Maybe we can go around. So Catherine, we've met, but Tyson, you're sort of next on my screen here.
Sounds good. So I'm Tyson Rosado. I'm one of the PGY6 student grads, as Dr. Acai was saying, out in BC here, currently doing, we're going to be working at RCH.
Excellent. Nice to meet you.
And I'm Eric. I'm also at UBC. I'm based primarily out of Prince George, kind of in the northern half of the province, and that's where I plan to stay for practice as well.
Lovely. And yeah, Jessica.
Hi, I'm Jessica. I am doing my geriatric psychiatry training here at Memorial University in St. John. So I'm just down the hallway from Dr. Hickey right now.
Oh, that's great. Wow. So really, we are all across the country. That's really neat. Well, thanks for joining. So yeah, in terms of how I've structured the session, I've started with kind of a general overview of quality assurance and some of the related terms. And then I talk about sort of a model for improvement, so some of the methods and tools that you might want to use, some strategies for success, and then some opportunities for application throughout. And please do stop me at any time if you have questions or you just want to, add your thoughts. I'm totally open to that. So just to kind of start us off, when you hear this term quality assurance, what comes to mind for you? Are there particular words, feelings, experiences? Feel free to shout them out or just put them in the chat.
I like to count to 5, and if the residents don't speak up, I do. So what comes to mind for me is accreditation.
Interesting. Okay. Yeah, absolutely. Anything else?
Go ahead. Go ahead.
I just think about things that we can do to reduce error in our clinical practices.
Mm-hmm. Yep, for sure. Reduction of error, accreditation. Awesome. Yeah, those are definitely things that come to my mind as well. Sometimes people think, I don't know, I've never, really had exposure to quality assurance. I really don't know very much about it. That's one that I've heard quite a bit. Yes, and surveys as well. So these are some of the things that, the literature suggests are associated with quality, and I guess some of the attributes of quality. So what is quality? Some of the words are accessible, effective, safe, as we talked about, patient-centered, equitable, efficient, appropriately resourced, something we've been hearing a lot lately, integrated and focused on population health. So this was taken from Health Quality Ontario, but it would certainly apply to other contexts as well. Are there specific aspects of quality assurance that you'd like to know more about? Is there any questions that you have or things that you're hoping that I'll cover in the talk today? Aside from a general overview.
I would be sort of wanting to get into how to put QI and sort of quality sort of projects sort of rapidly into place sort of in the clinical setting.
Okay.
Yeah.
Interesting. Okay, so rapid QI. Perfect. Anything else? Okay. All right. So I will try to talk a little bit about that. It's not one of my slides, but I can share some information throughout the talk. So let's just go over kind of a brief overview here of some of the terms that you might see in relation to quality assurance. So quality assurance itself is really making sure that our processes and procedures are meeting particular established standards. So I think whoever said accreditation is a great example, because there's a set of standards and we need to compare to see whether we're meeting those standards or not. So the focus is really on, are we meeting a specific, predefined set of standards? Increasingly, though, we've been moving towards the idea of quality improvement, which in some ways encompasses quality assurance, because you need to know whether or not you're meeting standards in order to know where improvements might be needed. And so I think in terms of the terminology we've been using, I've seen quality improvement used a lot more than quality assurance. But there's a lot of overlap here because both are systematic and formal approaches. Both are focused on identification of gaps, but with quality improvement, you're also focused on how we can actually fill those gaps and what do we need to do to create change. And I will also note that sometimes in quality improvement processes, the gaps aren't always based on existing standards. Sometimes we can find gaps that are not related to standards, but are still related to important parts of the program. So that's an important distinction there. And then program evaluation is something we also hear a lot about. And again, program evaluation is linked, but I would say it's a broader term because when we do program evaluation, we're really interested in sort of specific questions that are related to the program that may or may not be related to whether it's meeting particular standards or what areas it can improve in. Sometimes the questions are about other things, but at other times, quality improvement and quality assurance can be an important part of program evaluation processes. So I would see program evaluation as sort of a broader thing that encompasses or can encompass quality improvement and quality assurance. And just to understand where these concepts come from, the concept of quality management actually came from Dr. Deming, who was a statistician who worked in the manufacturing field. And he was really interested in making sure that processes could lead to as little waste as possible. And he found that when processes deviated away from a particular standard, where there was a lot of variability, as he called it, that led to a potential for waste and inefficiency. And his initial sort of focus was on people, but as he went on in his work, he realized that it was actually the processes that contributed to this kind of waste, as he called it. So he shifted his focus quite substantially from looking at people to looking at processes. And this kind of thinking only later permeated into healthcare. So you may have heard of the report To Err Is Human, which was sort of published in 1999. And it was a very well-known report that brought to light how issues around medical error could lead to patient safety concerns and actually led to a fairly high number of deaths. So these statistics are quoted often as, when we make medical errors, this is the outcome. And that focus on patient safety and making sure that, we weren't causing harm continued and has continued in the healthcare field. In 2001, there was another report that built on To Err Is Human, which really focused on what are some of the tangible changes that we could make in the healthcare fields to improve some of our healthcare outcomes. So, and that focus on kind of, improving the way that we do things has been a focus for a very long time. Any questions so far about anything I've shared so far? Okay. So just to kind of get into this a little bit more, what are some of the key similarities and differences that you see between quality assurance and quality improvement? And I also threw in research here just because sometimes I get a question around, okay, so how does this all, relate to research, which sometimes is a context that people are more familiar with. Any thoughts on this question?
I guess I think of research as a process of obtaining information.
Yeah.
Whereas, in quality assurance, we're looking at what's being done and trying to make, translate things into, I think, very relevant to delivery of clinical care. How do we take that information and deliver it in a way that's actually going to connect with people?
Yeah, I think you're really getting at that localized focus and that application focus of the quality improvement work. So really focused on how do we feed it back into existing processes? How do we make it better? Great. Anything else? Okay. Yeah, so like I was saying, with the quality assurance, because it was so historically focused on adherence to standards, some of the things that ended up getting emphasized was like individual performance, the idea that there's this kind of perfect way of doing things, and that when we don't live up to that, we're that's an error that should be punished. And that tended to be, because of the strong focus on standards, that tended to be sort of the framework. And as we've shifted towards more of a quality improvement lens, I think we've started to see that it's actually the systems and the processes we're evaluating, and people are a part of that, but people interact and work together. They're not just solo practitioners here. So it emphasizes more so teamwork. It emphasizes the idea that systems and processes are never perfect and that there's always room for improvement. And when we identify errors, we see them as opportunities for learning. So it takes a little bit more of kind of that positive psychology focus, where we're shifting away from errors, individuals, to systems and processes, and just generally ways to improve them. And then when we think about the relationship between quality improvement and research, it's kind of like you said, Eric, where it's really driven by the local context. The purpose is to drive improvements in a particular process or system, whereas in research, we're interested more so in just the production of new knowledge, contributions that are broader. So it might be to the literature, to the advancement of a field, but it's not necessarily directed at a specific local context. And also, I think that when we think about the goals, it's really application focused with quality improvement. We want to feed back the results to improve something in a local level. We might disseminate, we might publish, but that's not the goal. Whereas in research, obviously that is often the goal, is to, share our work via scholarly outputs and generate new knowledge. And the application might be there, but it's not always such an explicit focus as it would be in quality improvement. Any thoughts on kind of why we should do this? So what are some important reasons that we might engage in quality improvement?
Sort of better patient outcomes, or better staff satisfaction, better value in terms of improving and eliminating waste in the system.
Excellent. Yeah, that's perfect. So I think as healthcare providers and people working in healthcare, we obviously have a commitment to providing the best possible patient care, to use the resources that we have wisely. There's, of course, also accreditation, which holds our programs to particular standards. There's public perceptions, which I think are increasingly of note, where the public is aware of what's happening within our healthcare systems. And, these improvement processes can be important for sort of maintaining public trust in the healthcare system. And sometimes there's tangible rewards. So there's times where there's money awarded for quality improvement initiatives, or, programs that show a commitment to this get some sort of financial or other type of reward. So sometimes that is also what drives these processes. But I think there's also kind of a moral and ethical obligation as well. Okay, so how do we actually do quality improvement? One of the sort of models that I like, and that actually can be done relatively quickly, is plan, do, study, and act. And within that, sort of some of the key questions are around aim, measure, and change. So I'll go through each one of these. The idea is that this is a cyclical sort of cycle that you continue to go through and you continue to iterate. So it's not just something you do once, it's something that you do many different times, and you do it on an ongoing basis in a way that's hopefully sustainable. So AIM is about what are you trying to accomplish? So you want to make sure that these are really specific. When we say that we want to improve, you need to kind of specify by how much and by what time frame. So it's important to have that level of specificity. Let's talk a little bit about this AIM statement here. So we will create a truly interdisciplinary team to provide specialized patient-centered care for older adults requiring psychiatric care. Would you say that this is a good or a bad statement? I see you shaking your head. I agree. Not great. Any thoughts on how to fix this? Like, what would you do to make this better?
I'll throw out, you could perhaps do something, change it to say something. We'll work to create an interdisciplinary team by hiring 1 to 2 team members from each interdisciplinary group to provide care in the specific unit. To be able to review at 6 weeks, we'll measure patient outcome or something. Like, you'd want to have some way of knowing what are you seeing different.
Good. Yeah. So the level of specificity and things like truly interdisciplinary, it's kind of unclear what that means and in what time frame and in what context, for sure. So those are great ideas there. And then you actually get into measuring. So how do you know if a change is actually an improvement? You might look at outcome measures. So often this includes things like the patient voice. Sometimes you can speak to patients directly. Other times it's very challenging to do that. So you might need to look at sort of proxy measures that give you information about patient outcomes, but maybe less directly. So infection rates, wait times, fall rates, things like that. Outcomes aren't the only important thing. Processes also matter. So this is about how is the system working? You can look at things like compliance rates, supply and demand, high-risk patient intervention rates, etc. And what's really important to look at too is the sense of balancing. So you can't just look at things from one perspective. You need to take a holistic approach. It's very commonly the case that maybe you've improved one thing, but that's actually led to some challenging outcomes in another area. So you do need to take a more holistic sort of view of things as you're doing the measurement process. And these might include things like staff satisfaction or financial implications. So maybe you've implemented something new and it's reduced fall rates in seniors, but perhaps it's really increased the burden on your staff. And so that's something you need to be mindful of as you're doing this measurement process. Change. So what changes can we make that will result in improvement? So you can sort of have change ideas, which are specific changes that focus on improving specific steps of a process. You want these to be practical and easily testable. You can also have things that are called change concepts. So these are probably broader principles that provide a general direction for planning improvements. So you can see that something like balanced supply and demand every day is a broader concept that might lead to some specific ideas for how to actually implement that. So it can be helpful to have some broader guiding concepts for change, but then you want to make sure that you also have some really specific and actionable items. Change is actually something that is really hard to achieve, and a lot of what we do in our roles is often like change management. So it can be helpful to organize ideas for change into particular groups. So these are the change concepts that I was talking about. It's a lot more digestible if you say, okay, these are like the 3 core areas that we're going to focus on, as opposed to listing 20 or 30 action items, because people can get very overwhelmed by that. It's also helpful to prioritize the specific ideas that you do have for change. So maybe you have 30 things that you want to do, but it's not going to be possible to do all of them. So you want to prioritize what is important and which you need to test first. There's different analysis tools that you can use to do this. I just gave you I'll show you an example on the next slide, but it can be helpful to kind of do that prioritization process and then identify how you might implement and test each change idea. And now you can actually go into the cycle. So you plan, do, study, and act, and then continue sort of iterating that cycle as you go. This is just an example of one of the system kind of analysis diagrams that you can use, and it just sort of breaks down different areas, and then presumably they'd have specific sort of concepts within here that they would look to map onto specific effects that they're looking for. So it's just a way to visualize kind of your findings. It's not something you have to do, and there's lots of different ways of doing this as well. And just to kind of come back to this sort of plan, do, study, act cycle, this is just an overview of the different phases of the cycle. So in the planning phase, this is where you're really thinking about sort of what's the purpose here, what's your change idea, what are indicators of success, how are you going to collect these data, what do you think is going to happen? Doing is where you actually implement and collect data. Studying is where you analyze the findings, and acting is where you kind of decide, what refinements are still needed and how do we act upon what we have learned. And this is actually, if you're thinking about doing this rapidly, PDSA is something you can do relatively quickly. You can do it over the span of weeks, or you can do it over the span of years even. What you have to think about is the scope of kind of the indicators and the changes. So obviously, if you're doing it over a shorter period, you need to make sure that the changes that you're implementing are feasible within a shorter time frame, and that you're picking indicators that you're going to be able to collect in a couple weeks. Whereas sometimes when we're making huge, changes and we're looking at things that take time, that can take years. So we really have to be realistic about kind of the scope, but it works regardless of whether it's short or whether it's long. The approach is still applicable. And Cotter sort of proposes like these 8 ideas for how to manage change. So a lot of this is also how do we inspire others to kind of be on board with this vision. So there's a sense of establishing kind of that this is urgent. So really telling people, why are we doing this now? Why is it important? Why do we need to do this right now? And then sort of developing a vision and a strategy and making sure you communicate that, because if people don't know about it, then it's very unlikely that they're going to come on board. Generating short-term wins is a really important strategy. So if you can show that this change can result in some really tangible kind of low-hanging fruit type changes, that can be really effective from an organizational perspective. And then you kind of build from there. And hopefully you can create a system that you actually build into your culture, your organization, and that can continue over time. Before I get into ethics, does anyone have any sort of questions about PDSA or how you might approach doing quality improvement at a high level? Okay. So with respect to ethics, typically you don't need research ethics board approvals to do quality improvement studies, but if you're in doubt, definitely ask. There's sometimes a very gray line between what is considered research and what is considered quality improvement, so it can be helpful to get input on that. Research ethics boards can kind of review what you're proposing and also issue letters of exemption, which may be helpful if you're planning to actually publish the findings of your quality improvement study, because journals will often ask for proof of an exemption if you don't have an official approval certificate. And just because you don't necessarily need to go through the formal ethics board review process doesn't mean that ethics shouldn't be an important consideration in your work. In fact, it's totally imperative that you are fully understanding of the ethical aspects of the work you're doing and making sure that those principles are built in. So it is really important that you're still attuned to that as part of engaging in quality improvement. So this is just a little case for us to work through with respect to ethics. So the psychiatry ward has been experiencing challenges with patient abscondment, so people escaping the unit. They wish to test if certain new procedures, such as assigning in and out book, individual safe leave forms, patient information leaflets, appointment cards with agreed return times and contact numbers, intentional rounding, and visual procedural guidance for staff will help improve the issue. What are some of the ethical considerations that the team should be aware of in conducting this work? Any thoughts on this?
Well, of course, one of the big ones would be rights of autonomy for the patient in terms of their care. Do they have the right for voluntary, non-voluntary?
Great. Yes, exactly. I see patient consent in the chat here. Yes, that's very true. Very important. And that's actually a really good point. So I've run several sort of program evaluation, quality improvement type studies, and even though they generally don't require ethics approval, we still often do provide a consent form to patients, or whoever is involved in the study, just so that they're aware of what it is we're doing and that they consent to participating and knowing how their data are going to be used. And as part of that, we will generally specify what we plan to do with the data. So we'll say this will only be used for local change, informing local changes. Or this data may also, in addition to informing local changes, we may also be presenting these data, to people who might be interested and or disseminating via scholarly publications. So if that's one of the goals, is the dissemination, we like to make that really clear to people so that they understand exactly how their data are going to be used. Great. So how do we make sure that what we're doing is going to be successful? So I'll just give you a couple sort of tips that come from the literature and also my own experience doing some of this work. So it is really important to plan ahead. Sometimes you have more time than others. So obviously the level of planning will depend on how much time you have. But it is really important that you think about the whole process from the beginning, because otherwise there's a lot of things that can get missed and the process can kind of go astray if you're not sort of planning it out in advance and thinking about it. Work is part of a team. I can't emphasize this enough. First of all, doing this work on your own is incredibly time consuming, especially as you're also busy clinicians. But also, I think being part of a team can bring different perspectives to the table that will help make your work better. I've been in so many situations where just my own perspective, it just wouldn't have seen all possible angles of a situation, and having other people to bounce ideas off of is critically important. The other piece of it is that if you're implementing changes that are going to impact others, you want to involve those others in the process because they're more likely to want to be part of it if you've included them from the beginning than if they feel like you're imposing something onto them that they have to do. So if you can engage them as partners early on in the process and get their input, that can really facilitate this process. And this is just some considerations around assembling a team to do quality improvement work. It can be helpful to just think about how representative your team is. Do you have different perspectives? Maybe you want sort of clinical perspectives as well as folks who have more of a research or, quality improvement background. Maybe you want a mix of kind of support staff and sort of frontline workers. Sometimes people also bring in external partners depending on the nature of the work and whether that would actually provide a useful lens. And you also want someone who's going to take responsibility for actually leading the work, because if no one feels responsible, then it may not get done. You want sort of a core group or someone who's sort of the kind of point person and is going to make sure that the team is working together appropriately. So this is the part about project partners. So really thinking about how do we engage different partners in our work throughout the entire cycle. Partners may include patients, caregivers, clinicians, advocacy groups, researchers, policymakers. May not be everyone. You have to think about sort of your own project and which of these groups make sense for you, as well as how much time you have, because when you build in partners into your work, that is going to take time because now you're managing relationships and the project is bigger. But at the same time, it can be really important for making sure that this gets off the ground. So think carefully about sort of the partnership aspect of your work. And the role that the partners would play is quite extensive. So, obviously they're there to provide different perspectives. It can help increase the transparency of your work. It can help bring buy-in, which is really, really important. Support areas for expansion, increase public awareness, improve coordination. So there's really a variety of benefits that would come from bringing in partners in general into your work. And this is a 5-step process that you can use or keep in mind as you're sort of engaging partners in your work. So it's really helpful to define sort of the scope of the work itself and where the partners are going to come in, because it may not be appropriate for them to be involved in all parts of the quality improvement process, but you want to be clear as to what parts they should be involved in. And then you also want to decide who is most appropriate to engage. Create a structure. It can be really helpful to have like a sort of even like a memorandum of understanding or terms of reference document that's going to discuss how you're going to work together. How are people going to be involved in the dissemination? What are their roles? What happens if there's a conflict? These kinds of contracts or terms of reference can be very helpful to have at the beginning. You want to have multiple touch points where you connect with the partners that you've selected and share information with them. And you also want to have a way of assessing whether or not this is working. So, asking them or collecting a bit of information on the actual process itself. Yeah, Tyson, you had a question.
So I'm wondering, I know it sounds like you, again, from your experience, you do a lot of the sort of quality assurance and quality improvement type of projects. For those of us who don't do sort of have as much participation, would you have any examples so that of say some of these sort of structured or documents, so that if we wanted to engage with a project in the future, we're not spending time doing somewhat of that bureaucratic like paperwork generation for like, do you have any templates or things that you've found that you typically go to or use?
Yeah, good question. It's really been project dependent. So depending sort of on what we were doing, some of them quite honestly have been very small quality improvement efforts that have just been a really small core team and honestly didn't really have too many documents, things like that. I have been part of some larger groups where one of my colleagues does have like a sort of contract template for working together. So that is something that I found helpful. But yeah, other than that, I think it has really been project specific, with some of the projects being actually quite small in scope as well. Yeah. I can certainly ask her if I could share the contract document just so you can see what that looks like. Yeah. Another tip just to think about is to think about how to embed processes and ensure that they're happening iteratively and sustainably. So one of the worst sort of things that can happen is that the project is just a one-off and it doesn't really sustain over time. And it's like sometimes that is okay, but a lot of the times these things work best if they can be embedded into existing processes and there can be a cycle of improvement and sustainability. So it can be helpful to think about that from the start of the project, and especially if your role is more temporary, making sure that there's ways to that maybe there's folks involved who are going to be there more permanently, that there's actually processes built around some of these things that you've learned that can be very helpful. Does anyone want to share any factors that they feel might be important for affecting the sustainability of quality improvement initiatives? So what are some considerations here? Engagement. Yeah, engagement of stakeholders. Good. Anything else? Yeah, so in terms of things that can affect the sustainability, I think the biggest one I've seen is people. Like, often the people that are doing this work may not be permanent members of the areas that they're working in. And so when they leave, these processes kind of dissipate. So that's why it's important to have that team that's going to have some folks who are more permanent, also where you can create kind of processes that can stay in place even after the people leave. Other things that I've seen have been sort of where there's a misalignment between the project and then the broader cultural or political factors. So if there's, changes you're trying to make, but they don't really align with kind of the broader context that's in place, that can really undermine change efforts. Of course, things like leadership, finances, the timing also matter, but I think really just thinking about the broader culture that you're working within, and also like your own role within that system can be very helpful. So again, supportive management here, of course, very important. Structures that go beyond people. So yeah, formal policies and procedures or systems that are put in place. And I think it's also important to have ways of getting feedback. So, if something has been implemented and it's not quite working, how do we collect information about that? It is helpful for people to have kind of a shared understanding of what needs to be changed. And that's why I say bringing in those partners can be very helpful to create the buy-in. And you want there to sort of be that culture that's going to facilitate these things from happening. So that's very important as well. I would also suggest, trying to keep it manageable. A lot of these projects, they can get really big really fast. And sometimes the best ones I've seen have just been quite focused and small quality improvement initiatives, but that are really, you really take the time to establish the ideas and collect the data. Like, that I think can be much more successful than these huge change initiatives that are just so big and overwhelming that they actually maybe don't work in the way that you were hoping they would. So I can't stress the importance, especially if you're starting out, to just kind of keep it as manageable as possible. It does not have to be big and scary. It can be small and focused and still be impactful. The other important thing is to really disseminate and share. There's lots of ways to disseminate. It does not have to be formally through scholarly means, although that can be helpful. But, if you've done something and you've taken the time to create changes, collect data, and you don't share it back, it's almost a loss, because, then people don't know about it, and maybe they're going to go and do the same thing next year, and it just becomes sort of duplicated efforts. This is just a statistic from a publication that they had done looking at projects that were submitted for local presentation, and they found that only 6% of them were published and 12% of them were presented at a national or international level. So it's just an example that, again, not everything has to be disseminated widely, but at the same time, it can be helpful to share so that people, again, aren't duplicating their efforts. When you're thinking about dissemination, definitely think about sort of what are the things you want to actually share. Who are you sharing it to? Because that's really going to impact the specifics of how you frame that information. And are there people that you want to partner with to help you share the information? What's the best modality? And how will you know if your dissemination strategies have been effective? And it can be helpful to have ways of trying to see that. How would you, so if you were doing a quality improvement project, how would you decide what parts of your work to share and how, and what are some possible ways of sharing? Does anyone have any experience or ideas around this part? And you can think beyond just the traditional sort of scholarly publication and presentation, although those are also valuable.
there'd be things like journal clubs, research papers, poster presentations, conference presentations, grand rounds, etc.
Good. Yeah, excellent. Yeah, so definitely got your traditional methods, publications, presentations, reports. I've seen some really great infographics, especially kind of on a local level. You might actually implement like training or curricula, that actually encompass some of your findings. Or maybe it's a data collection tool. Maybe it's a new form or a new survey that you've developed based on your findings, or a decision support tool as well. So there's lots of different ways that don't necessarily involve as much work as, publishing something or going to a national or international conference. So I do have a little case study here that we can work through as a group. So this is just a case study on reducing falls. So the new director of a rehab hospital points out that the organization's falls rates is much higher than that of other similar organizations. And after exclamations that this hospital's patient population is much sicker, managers and clinicians finally agree that the rate is too high. The rehab facility holds a facility-wide falls fair to educate staff about the common causes of patient falls and prevention, but ultimately the fall rates for the next 3 months remain high. You are tasked with leading a quality improvement initiative using your newfound skills. What would be your next step here? So how would you approach this? How would you start?
Starting a names process.
Okay.
Like beginning with a PDSA cycle. So we're setting out like what is the sort of vision statement, who's going to be part of it, setting out what are we actually going to want to measure, how are we going to measure it, setting out sort of the specificities in terms of the time frame over which time we want to do that.
Great. Yeah. So having some specificity, and it seems to me like this falls fair might be one of the things you want to investigate. So maybe you want to build something in where you're going to ask people like, did you know about this? Did you go? How was it? Was it helpful? Because you might uncover that maybe no one knew about it. So maybe it's a communications issue. Or you might discover that it actually wasn't effective because people see the issue as being something else that this isn't addressing. So definitely taking the information you have and trying to build something around that. Great. And so now you've looked at some of the data and you see that the unit with the highest number of falls cares for relatively mobile residents with mild to moderate dementia. So what would this tell you? Where is this going to lead you if you have this information? So to me, it might lead me to kind of hone in on this specific unit. So kind of understanding, obviously this falls fair they implemented seemed to be widely, have a wide audience. It was targeting sort of a larger number of staff, but it sounds like maybe there's a smaller group here that you need to focus in on and really understand their experiences and whether they're actually, there's specific issues going on in this context. So much has been written about falls reduction with evidence from successful programs, and this offered many good improvement ideas. Your team decides to implement a falls risk assessment process to prevent falls. So once you've implemented this, what would you do next? What are some important considerations? Is there a way that you could sort of evaluate this? Like, do you have any ideas about that?
could just sort of identify again through that patient environmental piece. It's like baseline falls at the current time. What's the goal that we want to get to? Sort of, and you look at adverse outcomes, sort of hip fractures, like surrogate markers for falls.
Mhm.
You could also look at care burdens for staff or family members, and the surrogates from that, such as like workplace injuries or things like that.
Great. Yeah. So you're looking obviously at the patient outcomes, whether it's a surrogate marker or direct, but also at the markers, the potential impact on the staff who have to implement this program and what their experiences are. Great. Okay, and so over the following months, your team continues to test changes, measure results, and build changes into the new procedures and orientations for new staff. And after 9 months, the falls rate reaches the team's target. So what are some steps you can take to ensure the sustainability of this positive outcome?
I think you could continue to measure the fall rate over time.
Good.
And if there's any deviation, you could do another analysis of what contributed to that. Sorry, I
Great.
think I interrupted somebody.
No, that's okay. That's great. Yeah, so the continued measurement, continued collection of data. I think maybe it sounds like there were changes built in procedurally, but ensuring that that's reflected in written documentation that this program is going to continue. And if there were specific things like that were being done in terms of a curriculum, or that should be shared, so that it's not just held with one person who's delivering this orientation, but it's kind of available to the broader team in case that person ends up shifting. And you might want to just share this as well. You might want to share this locally, but also maybe in some other ways as well. Great. Okay. And lastly, I am curious if anyone here is working on any quality improvement projects, and if you want to, or has in the past, and if you want to share a little bit about your experiences and what that was like for you. Or are there ones that you hope to do in the future?
Unless any residents speak up, I'll just ask a question which might be relevant to a lot of these different projects we might consider with older adults. I'm just wondering how we can effectively survey patients, because it seems to me that we're in an environment all over Canada, really, where patient safety is paramount, and our population often gets overlooked. Many of our patients are frail. Many of our patients have aphasia. Many of our patients can't advocate for themselves. So I'm just wondering if anybody here on the meeting wanted to survey patients to get a sense of whether or not we're providing safe and effective care. How can you best go about collecting that data? I've kind of thought maybe we should have something in our waiting room, like something that's, just like, a simple series of questions, large font, but I'm not sure. I'm sure that this has been encountered by many people. I'm just wondering, do you have any resources you could recommend for that kind of thing?
Yeah, not offhand, but certainly patient population, like patient surveys are definitely a thing. I think some of the considerations are like timing. So, a waiting room is a very common place to do patient surveys, but then if you're evaluating something about their visit, it might be too early. So sometimes people do like an exit survey, or something they can send electronically nowadays, actually, but kind of depends on the patient's level of comfort with electronic surveys. And also it can be, you should think about who's administering the survey, because if you're also the one providing care and then you're also administering this survey, then people may not feel comfortable at all doing it, or if they do it, you might get biased results because they feel like they need to answer a certain way. So Where we have done that, we've often employed like a research assistant who has no relation to the patient care, or a staff member who's in that role rather than the clinician themselves. And yeah, often it is either it's done kind of on paper at the end of the visit or while there's a waiting period, or I have seen like in some, there's more general clinical settings, but just, yeah, the electronic survey so that it really feels distanced from the clinical encounter. Obviously the risk there is the response rate, but it can feel more comfortable for the person because they're not like being accosted with this data collection tool. So yeah.
The other
Okay.
thing that I've thought of, Dr. Hickey, is thinking about the validity of the data. Unfortunately, in our geriatric population, we have often our patients with neurocognitive disorders, and are they able to appreciate, understand, depending on the severity of it, what's actually being asked of them? And so thinking, do you have to have a surrogate respondent, and or again other measures for that if they're severely impaired, perhaps, but again, where possible, of course, obtaining from them.
Yeah, that's a really important consideration, is like the level of sort of how you think the data, the integrity of the data would be based on where the patients are at. Maybe there's a caregiver with them that can provide some information, or there's some proxy measures that you could do instead of a survey if you just feel like it wouldn't be helpful. Yeah. Any other sort of questions or thoughts on this? Okay. All right, so I've got some resources here. There's several like guides and sort of handbooks that are available online that you might find useful, that have some tools. Also, if you have kind of a specific area that you want to do quality improvement in, I would actually look it up, because oftentimes there's existing literature on that topic, and they may have methodologies that they've already written about, and maybe even data collection tools that they've already published that you could use. So it depends on the specific project, but often just a quick search of the literature is very, very helpful. There's some online resources as well. Some are free and some are paid that you can take if you're interested in quality improvement and quality assurance. And I can certainly try to locate that contract from my colleague, and if that would be helpful for folks.
Well, I wanted to thank you so much for that. I really enjoyed it. I really liked the interactive nature of the presentation, because it really made us think, okay, what is quality all about, and how do I apply to my practice? So I want to thank you for that so much. And I hope you'll come back next year and do this presentation again. And we will get the recording up on the website, hopefully within a week. And again, thank you for your time. I really enjoyed it. And I want to congratulate all of the PGY6s on the completion of their residency. It has been such a joy to get to know you all over the last year. And for anyone who's going to the CAGP in St. John's in September, you have to email me. I think you all have my email address, but Dr. Sang and I will be there, and we'd love to welcome you to St. John's. So thanks again, everybody. Good luck on the exam, and hope I'll see some of you soon. Bye now.
Thanks, everyone. Congrats.
Okay.